بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Dear colleagues, ladies and gentlemen, respected guests, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to welcome you here in another wonderful session of the IMC Family Medicine Club, number 42, which we have been striving to provide you with this kind of series of up-to-date sessions to enhance our capacity and capability as a family physician and primary care physician in different fields of specialties. Today, ladies and gentlemen, we are going to have a very important topic that is related to cardiometabolic crossroads. So we are tackling two important entities. One is prediabetes and the other one is overdrive for hypertension. And of course, as you know, that prediabetes is almost forgotten. And we have spent a lot of effort just to tackle the major problem of diabetes as a disease and a complication. But we have to address that there is certain stage, an early stage where we can intervene and we can exert some limited effort for a better outcome, where we have to treat the prediabetes as a disease and to prevent the patients or to delay the onset of diabetes and the complication of diabetes. Moreover, on the other spectrums, hypertension, because of the overdrive, is another common problem that we have here in our society, and it's impacted our patients with a lot of consequences in terms of the cardiovascular morbidity and mortalities. And both these problems combined together constitute a major component of the mortalities in our society of the Kingdom of Saudi Arabia, which has been presented or estimated to be 37% of our total population. They die because of the cardiovascular event, contributed by these two elements as a major component. Today we have been privileged, as usual, to have two eminent speakers, and of course I'm very honored to have them as a senior consultant in their specialty. We have Dr. Abdul Hamid Hassan, who is a consultant family medicine in the International Medical Center, and we have Professor Tahir Hassan. He's a senior consultant invasive cardiologist. So both of them, they are going to join together to help us to understand these two clinical entities in depth, in fact, and we will be able at the end of this session to come up with certain take-home messages so we can implement it in our clinical practice tomorrow onward with the full confidence that we can manage our patients appropriately and demonstrate the state of art in managing these cases. So I would like to extend my thanks to the Merck Company for giving us this wonderful opportunity to be here together today to share experience and to exchange knowledge in these two topics. And I would like to thank the Saudi Society for Family and Community Medicine, because under their umbrella we have been able to go ahead with this kind of scientific events, not only physically but also virtually, where we are joined together today to have more than 2,000 attendees. I'm very sure that this topic and this session will be quite fruitful for all of us. So stay tuned, be focused, and be ready to ask questions to cover all the concern that you might have in these two topics. So we will start by Dr. Abdul Hamid Hassan, who is a consultant family medicine, International Medical Center in Jeddah, and I owe him a lot because he was my teacher in certain point of time until today. I'm very proud to have him as a reference, not only him, but also Dr. Tahir as well. And this is the way we always manage ourselves to enhance our expertise in medicine all our life through. We are in the state of being a student to learn more and more every day from our own senior experts. So Dr. Abdul Hamid will talk to us about the prediabetes, and this will be followed by Dr. Tahir. So please make sure for the online attendees to put their questions in the Q&A box, so we'll be able to collect their questions and to convey to our experts. So thank you very much for all of you attendees physically and virtually, and wish you a very fruitful session. Thank you.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم والحمد لله رب العالمين والصلاة والسلام على سيد المرسلين. Thank you all for attending this session. Thanks Dr. Ashraf for this introduction, and thanks for our colleagues attending virtually. And I would like to thank Milk Solono for sponsoring this activity. Today we are going to talk about prediabetes. But as usual, I would like to go to review some recent updates in the medical literature regarding diabetes. The first paper, by the way, all are coming from New England Journal of Medicine Journal Watch. This special service from New England Journal of Medicine. You subscribe it, they review all the literature worldwide, they selected important papers or articles or guidelines, and they commented on the paper. So what you are going to hear, the comment from the New England Journal of Medicine about this paper. So the first paper, talking about continuing metformin in hospitalized patient will help the outcome. The comment of the New England Journal of Medicine said that an observational study suggests inpatient continuation is associated with lower risk for hypoglycemia and death after discharge. So don't stop metformin for those who are admitting patients with hospitalized. The second paper, how safe is metformin in stage 4 chronic kidney disease? So we used to reduce the dose of metformin and stop it according to the level of GFR. This paper was published in the American Journal of Kidney this year, and the conclusion, the comment of the New England Journal said diabetic patient with GFR less than 30 who continued metformin had lower mortality at 3 years. So it is safe to continue metformin for such patients. It's still not approved by Saudi FDA, but this is a paper showing that it is a safe intervention. Do diabetes medications help asthma? Yes. The paper said metformin and GLP-1 seem to prevent some asthma exacerbation. A new area in the metformin benefit and a new area in the GLP-1. Next. Intensive versus standard blood pressure lowering in patients with diabetes. This paper was published in the New England Journal of Medicine itself, and it showed ده ما بيشتغلش ولا ايه؟ ما هو a randomized trial lowering systolic blood pressure to around 120 results in fewer strokes. You remember the so-called accord. For many, many years ago, we struggled about talking about accord. When you tell intensive blood pressure reduction, all physicians said, but accord said, don't lower the blood pressure. Don't lower the blood pressure. No. Now we have evidence published in New England Journal of Medicine that lowering blood pressure in diabetic patients around 120 is much, much better than 130 or 135. So go the lower the better, even in diabetic hypertensive patients. Benefit of early glycemic control. This paper showed that after 24 years, patients who received the early treatment still had a lower risk of mortality and other events. The conclusion of the original paper said that early intensive glycemic control with sulfonylurea or insulin or metformin compared with conventional glycemic control appeared to be near lifelong reduction in the risk. So be very aggressive from day one. From that you diagnose diabetes, lifestyle, and 1 drug, 2 drugs, 3 drugs, you should be lowering the A1C to the lowest acceptable level to save your patient after 24 years. So don't be reluctant, don't be hesitant to intensify the treatment to achieve a 6.5 A1C level. This paper showed that following them after 24 years from early intensive management was very, very useful for our patient. Bariatric surgery is very good for the management of diabetes. However, the comment of the New England Journal of Medicine said the effect wane after years. So whether medically you reduce the body weight or by surgery, the effect will be maximally with surgery, but after 10, 15 years, the effect will be equal to the medical intervention. So metabolic surgery are very good, but also medical interventions is very good. Treatment of diabetes and dementia risk. Metformin decrease the dementia risk in older adults with type 2 diabetes. So for geriatric patients, metformin will be very safe, not only for diabetes control, but also for dementia protection. All insulin diabetes drugs, all drugs other than insulin during pregnancy. This paper published in JAMA, and the maternal use of such drugs, they mentioned a lot of drugs at that time. GLP-1 and SGLT2 were not included, including metformin, compared with insulin, was not associated with increase of congenital malformation. So they are even safe during pregnancy. But you need to follow the Saudi FDA indications for the medication to use during pregnancy. Gestational diabetes and early mortality. Again, this paper said that gestational diabetes is very, after 30 years of follow-up, history of gestational diabetes is a very bad omen. So that's why the recommendation that patients with history of gestational diabetes should be screened for the development of type 2 diabetes in the aggressive guidelines every year. In the ADA, every 3 years. So at least every 3 years, you need to screen for diabetes for gestational, those with history of gestational diabetes. Now we are going to talk about the prediabetes. I will cover the importance of early treatment, then the data from Diabetes Prevention Program and Diabetes Prevention Outcome Study, and the Chinese Diabetes Prevention Program and the management of pre-diabetes. This is statistics about Saudi Arabia, and it was since long time. So in 2011, we don't talk about pre-diabetes too much. That's why there is no pre-diabetes in 2011, not only because it was not present, because it was not mentioned. Then in 2024, you can see 1 every 4 patients have diabetes, and the pre-diabetes, whether impaired fasting or impaired glucose, there's 17 and 15%. The future is not good, because in 2050, the prevalence of diabetes will be 25%, 1 every 4, and the pre-diabetes 20 and 15%. So it is very common. That's why we should tackle the problem from the beginning. How to diagnose pre-diabetes? You can diagnose it by fasting blood glucose if it is more than 99. So please, any patient in your clinic, if his fasting plasma glucose is 100, don't tell him you don't have anything, your glucose is normal. No, he has a serious problem named pre-diabetes. He has a possibility to develop a serious disease called diabetes. So don't tell him you are normal, your glucose is normal. No, his glucose is abnormal. Please, patient engagement is very important. Our culture is not interested in these numbers. Our culture is interested in vitamin D level, not in A1C or fasting plasma glucose or LDL. We should change this culture. So 100 fasting is abnormal. So don't tell the patient your glucose is not. 2 hours, 75 gram glucose, 139 is normal, 140 is abnormal. 140 is pre-diabetes. So inform your patient that you have pre-diabetes if the blood glucose is, after 2 hours glucose, 75 gram glucose is 140 or more. A1C 5.7 is pre-diabetes. So don't tell him your glucose is normal. You don't have diabetes, but you have a serious health problem called the pre-diabetes. You have high probability to develop diabetes in the future if we don't start together to take care of what's going on. Risk factors are well known. Obesity, family history of diabetes, gestational diabetes, hypertension, dyslipidemia, all these are risk factors for prediabetes. Prediabetes carries 11% of the patient with prediabetes will convert to diabetes every year. So it is a serious problem. And 70% of patients with prediabetes will develop diabetes by eventually. So it is a serious problem. The patient should start to take care. His family should help him to reduce the meals, to reduce body weight, to start exercise. We give him medications, as I will show you, because it is a serious problem and the probability to develop diabetes is very high. This is the risk for developing diabetes. If the A1C from 5 to 5.5, the probability is very minimal. If from 5.5 to 6, the probability increase up to 25%. If it is more than 6 to 6.4, the probability jump to 60% probability to develop diabetes. That's why in my clinic, I used to tell my patient, you have mild pre-diabetes or severe pre-diabetes. Mild pre-diabetes means fasting from 100 to 110, 2 hours glucose from 140 to 160, A1C from 5.7 to 6. Above these levels, it is a serious pre-diabetes. The probability is 60% to develop diabetes in the near future. So we should be more aggressive in the severe pre-diabetes. This is my classification. It is not the ADA classification. But I tell my patient, you have mild pre-diabetes or severe pre-diabetes. So I will be more aggressive for managing pre-diabetes. These are, as you know, back. One slide back. Thank you. These are the well-known complications of diabetes and the pre-diabetes. We can diagnose retinopathy and the neuropathy in patients with pre-diabetes years before developing diabetes. And the macrovascular complications, heart failure, all these are there during the pre-diabetes stage. So we should be aggressive at this stage. Don't wait till it is a full-blown picture of the disease. The Diabetes Prevention Program and Diabetes Prevention Program outcome studies. The Diabetes Prevention Program, the objective of the program to reduce 7% of the body weight, baseline body weight, and to exercise 150 minutes every week. Next. So low-calorie diet and the low-fat diet and exercising. Next. ممكن the intervention is very effective in reducing the possibility of developing diabetes. Whether the Chinese study showed a reduction by 50%, in Finland, they achieved the 60% reduction. The Diabetes Prevention Program, original one in the States, reduced the probability by 60% also. And in Japan, 70% around. And in India, it is 30% reducing the risk of pre-diabetes, from going to diabetes. But the challenges are very well known. The adherence and the relapse. For any lifestyle intervention, the adherence is very poor and the relapse is very expected once there is poor adherence. Difficult to maintain the achievement and the compliance and the regain of body weight lost after a while. Regain of lost weight. These are the challenges of lifestyle modification. But they are very effective and should be the first step, or the first step beside metformin, as we are going to see in the management. For everyone, it is not suitable for lifestyle modification. I got a patient working in the desert in Aramco, and he told me, I cannot adhere to lifestyle. The meals are coming to us, all of us, the same meal, not high vegetable, high fiber diet, low fat. And I cannot exercise in the desert. So he cannot implement from day one lifestyle. So no way to try, no way to waste your time and your patient life. It is not the patient time, it is the patient life. So don't waste his life, don't waste your time in talking about lifestyle if he is not able to implement lifestyle modifications. This is patient who could maintain the weight lost after 1 year. And this is for the comparison between those who started lifestyle modification. They achieved in 1 year almost 6 kilograms, but they gained weight after that and continued in plateau. So the adherence is a problem, and the maintenance is a problem, and the regain of the weight lost is a problem. This is the trials. When we add metformin to lifestyle modification, we could achieve in some studies almost 90% reducing the risk to develop diabetes if we combined lifestyle with metformin. The diabetes prevention program and the continuation of the program called outcome study, the first 5 years was diabetes prevention program, lifestyle, or metformin or placebo. Then the extension, it is for 10 years. We have now data up to 15 years of the outcome study, and whether modified intensive lifestyle or modified intensive lifestyle with metformin or modified intensive lifestyle alone. And the design of the original program was 3,000 patients, and they have pre-diabetes, and the duration beginning to 8 years, and then this is the lifestyle, low fat diet, high fiber diet, and exercise. Then adding metformin, 850 milligram twice daily, and lifestyle compared with placebo, and discontinuing torglitazone because of the hepatic toxicity. The outcome of this first phase of the trial, as you can see, adding metformin achieved a more 31% reduction in the risk to develop diabetes. Weight loss, we can achieve more 18% reduction in the developing diabetes by reducing weight. The outcome study, 10 years from the start, this is the weight loss. As I said, with lifestyle, we could achieve excellent weight loss, but it is only for 1 year. Then there is a regain of the lost weight after that. But with metformin, we can achieve and maintain the reduction, the success after starting metformin. This is for 10 years. For lifestyle plus metformin, it was cost saving, and it was good value for the money spent. I don't agree with this, because they calculate the cost of the medicine and the expenses of treating diabetes, but they didn't calculate the cost of the complication of diabetes. As a family physician, I am not interested only in the complication of the patient with diabetes. I am interested at his family. If we have a family member with hemiplegia or amputation or dialysis, this is a serious cost. So if we can calculate this cost by preventing the development of diabetes, by preventing the development of complications, we are saving a lot. Not only the money, but also the psychological stress for the patient and his family. So it is very, very cost effective. It is not just cost saving or balanced value for the management. For 15 years, extension of the trial again showed a beneficial effect maintained by adding metformin to lifestyle modification. Microvascular complications, again, it reduced by 28%. This is for the patient with diabetes and patient without diabetes. If we prevent the patient from developing diabetes, we can get a better benefit by reduction by 28%. The last part will be the management. This is a Chinese study, similar result. The adding metformin improved the reduction of the risk for developing diabetes by 17%. And these are the risk factors for patients at serious risk to develop prediabetes, and who will benefit more from adding metformin to lifestyle. So those aged less than 45 or with obesity or hypertension or obesity and hypertension, they benefit more from adding metformin to lifestyle. But the ADA said all patients with prediabetes, if they are younger than 6 years of age and the A1C approaching 6%, metformin is highly indicated. This is the reduction of weight for the intervention group and the control group. There's a difference for the weight reduction. And the last part will be the management. As we said, lifestyle is very important. This is the International Diabetes Federation said the cornerstone of type 2 diabetes management is promoting lifestyle. If change in lifestyle are not sufficient to control blood glucose, oral medication is usually initiated with metformin first line. And the only approved drug till now in Saudi Arabia for prediabetes is metformin. Metformin, according to the American Diabetes Association, is considered for impaired glucose, impaired fasting, or A1C more than 6%, with obesity more than 35 kilograms square and the age younger than 60%. He can benefit over the coming 20 years from the intensive correction of the pre-diabetes stage. The Canadian Diabetes said the same. Implement a lifestyle intervention to prevent type 2 diabetes. In the stage of pre-diabetes, metformin may be considered in people with impaired glucose tolerance. Lastly, the Saudi National Diabetes Center, metformin to be considered in all these categories of pre-diabetes, whatever the diagnostic point, especially if body mass index more than 35 and age less than 60. But if the patient cannot implement and maintain lifestyle, I think even once there's pre-diabetes, metformin could be used. The prediabetes has no sign and symptom. Unfortunately, 90% are unaware. And patients with prediabetes, in addition to lifestyle, metformin should be used, especially in those at very high risk. That means those who combine both impaired fasting and impaired glucose, those A1C fasting more than 6.1 millimole, impaired glucose plus obesity, A1C more than 6%. Those who failed with lifestyle or cannot implement or not adherent, impaired glucose with age less than 60, and the previous history of gestational diabetes. We need to screen for diabetes and pre-diabetes. you need to perform the test whether fasting or postprandial or A1C. For first degree relative of type 2 diabetes, next. History or a high risk race or ethnicity, history of cardiovascular disease, hypertension, dyslipidemia, women with polycystic ovarian disease, physical inactivity, or any other condition associated with insulin resistant like acanthosis nigricans or severe obesity. Number 2, you need to screen patient with prediabetes really, so it is annual. Women with gestational diabetes, as I told you, ADA every 3 years. The American Association of Clinical Endocrinology annually. For gestational diabetes, patients should be testing beginning without all these risk factors by the age of 45. It is universal screening, and if the results are repeated minimally every 3 years or even more short interval. Metformin XR for prediabetes. The result of diabetes prevention program and the outcome study showed that metformin extended release or XR give bioequivalent results with immediate release metformin. Gastrointestinal side effects are minimal with metformin extended release. Next. Next. Gastrointestinal side effect minimal by 50% for all adverse event and for diarrhea by 77% compared with immediate release metformin. Next. Improve adherence because it is once daily, and one of the slides insisted that twice it was mentioned. Metformin XR should be given once daily. Even if 2 tablets, 2,000, it should be once daily in the evening with the evening meal. And the adherence, once we improve the side effect and the once daily, the patient will be more adherent. And once he is more adherent, the improvement will, the outcome will be more. That's why the reduction in A1C was better in patients using metformin XR compared with immediate release metformin. Bioavailability, they are equal, but the adherence here get the edge over for the extended release over the immediate release. So in summary, prediabetes is a cardiometabolic risk factor. Prediabetes associated with increased cardiovascular risk independent of the diabetes development. Not all prediabetes progress to type 2 diabetes, but many will progress. Lifestyle is very important. It is the cornerstone. If adhered to, metformin is the only approved for Saudi FDA drug for prediabetes, and individualized treatment. Regular monitoring is very important. Thank you.
Thank you so much, Dr. Abdulhamid, for this illustrated presentation, shedding light on prediabetes. And now we realize that prediabetes is a disease. It has its own complications and it has its own consequence on the cardiovascular mortality and morbidity. And the management, the state of art of management is the lifestyle modifications as well as metformin to be used. So I think it's a good opportunity for you and for all of us as a family physician to put prevention into the real world practice by preventing the fast progressions of prediabetes to diabetes. So thank you so much, Dr. Abdulhamid, for this highlights. And now we will move to another important presentation, which will be another topic of interest for all of us, which is turn down the overdrive volume. And this is by Professor Tahir Hassan, who is a senior consultant intervention cardiologist And I owe Dr. Tahir for being with us here many, many times. Every time he surprises us with a lot of informations and a lot of updates that really sharpen our skills and add to our competencies a lot of values. So thank you, Dr. Tahir, for being with us here today. And I'm looking forward to have a very fruitful, wonderful session as usual. Thank you so much.
Bismillah ar-Rahman ar-Rahim. Thank you very much for inviting me. It's always a pleasure to talk to our colleagues from the family medicine. Mr. Chairman, thank you for introduction, and thanks to Merck for this kind invitation. Now, from the title, you see how to turn down the volume. What volume you are talking about? Is it sound volume or the noise volume? What kind of volume that you want to turn down? I want to turn down the stress, and I want to turn down being always tense, anxious, fearing, fight and flight. I want to turn down a volume that causes your heart rate to go fast. I want to turn down the volume that causes your blood pressure to go fast. I want to turn down the volume that causes complications in patients that have hypertension. So what kind of volume should I turn? I choose to turn the sympathetic overdrive volume, because by doing this, you can achieve benefit. Here. So I will try to be more practical. It's 10 o'clock, and I feel everybody wants to sleep, but I want to engage you in the talk. So the first thing is understanding what is the sympathetic overdrive. This is the central nervous system, and for a reason where this is stimulated by reflex mechanism, stimulated by insulin resistance, stimulated by angiotensin II receptor, angiotensin stimulated by leptin. This will produce norepinephrine and epinephrine, and that works on every single body. On the eyes, it makes the pupil dilated, it dilates the bronchi, it accelerates the heart, it causes different effect on different organs of the body. The sympathetic overdrive is actually meant to be for energy balance and regulation as well as blood pressure. But an overdrive is behind cardiovascular mortality. It's behind all risk factor, as I'm going to show it to you. Let us go. It chooses this one. Being a cardiologist, what the sympathetic overdrive will do to us. It will release norepinephrine. And norepinephrine works in two important organs that's important to us, the heart and the kidney. When you stimulate the heart, it increases the heart rate, increases the heart rate variability, and it causes hypercontractility of the heart. And when it works on the kidney, it causes an excessive release of angiotensin. Both these factors will, together with norepinephrine, will exert a mechanical effect on the vascular damage causing plaque rupture. So you end up with having patients that have tachycardia, hypertension, and angiotensin in excess, and the mechanical damage that can cause at any time, particularly in the early morning hours, plaque rupture and an acute coronary syndrome. I want to tell you one important thing. It's not blood pressure that cause event. Blood pressure cause event mostly when it is associated with increase the heart rate. That's why when you check the blood pressure of the patient, always they come and say, oh, he has a very low diastolic blood pressure. I don't care about that, because when you grow elder, the diastolic blood pressure goes down. So I always tell to the patient, check two things, or to the physician, blood pressure and systolic blood pressure in the elderly and the heart rate. You do this 4 quintile. The first one, when you have a high heart rate and uncontrolled blood pressure, the event rate is high. If you manage to keep the blood pressure controlled, but still the heart rate, then the event is there. And when you go down, when you can have the heart rate is controlled, but blood pressure is uncontrolled, it is better than to control the blood pressure. And definitely the best thing is to look at the patient from the perspective of hypertension and heart rate and reduce them, because that makes difference in the incidence of endpoint by 53%. So we have to come out of this room knowing that patient with tachycardia and hypertension carries a higher risk than having hypertension alone. And that was seen in several studies. In young generation between 50 to 53, when you increase the heart rate, then you are inviting an increase in cardiovascular death, fatal MI, and total death. And here in the French studies in patients less than 55, heart rate, when it is above 100, it's more associated with coronary heart disease and cardiovascular disease, more than patients that they have their heart rate is low. Diabetes, and we talk today about diabetes. In diabetic patients, they are more vulnerable to death and cardiovascular complication if you leave them with a tachycardia. The prognosis on tachycardia is higher. The event is higher when the heart rate is fast in diabetic patients. Second part is hypertension. What's the magnitude of the problem? And the sympathetic overdrive and therapeutic option in hypertensive patients. When we look globally, the global report on hypertension, you find that we are not doing well in management of hypertension. Hypertension affects about 33% of the population. And nearly half of the patients who are non-hypertensive, they are aware that they are hypertensive. Half of them, they are not aware. 80%, they are uncontrolled, and we seldom control more than 20%. So our performance in hypertension management is not up to standard and need to modify. Why we tend to treat blood pressure down to a good tight control? Not only for the sake of few millimeter mercury reduction, it's to reduce heart attack, to reduce heart failure, to reduce stroke, prevent kidney damage. That's very important. And moreover, when you do that, you are reducing the economic burden on managing cardiovascular disease, which was $3.5 billion in year 2016, projected to increase to $9.8 billion in 2035. Looking at Saudi Arabia, the incidence of hypertension, of prevalence of hypertension is nearly 30%. 55% of the population, they are not aware that they are hypertensive. So overall rate of control is less than 50%. And doesn't come alone. It comes with obesity, diabetes, hypercholesterolemia. I want to go back a little bit. Yeah, before. Yeah, okay. Next one. Next. Can you read the next one, please? Or shall I do it this way? Okay. So, knowing that the sympathetic overdrive is very important in hypertension, we look of all medicine, which medicine can reduce the sympathetic overdrive, whether the peripheral or the cardiac one. And that's only the beta blockers. The beta blockers can oppose the sympathetic overdrive. No other medication can do that. And they were saying that angiotensin II receptor blocker can reduce them, but in reality, it's not. Look at the ebrosartan here. When it was administered to the patient, it showed that it's more sympathetic, muscle sympathetic nerve activity. It reduced the blood pressure, but increased the heart rate and increased the sympathetic activity. Next. Yeah. So when you come into your clinic with elevated heart rate, there is three ways of managing the elevated heart rate. The best thing is to give a beta blockers, because the beta blockers, without intrinsic sympathomimetic activity, control the heart rate through controlling the sympathetic overdrive. But looking, for instance, like verapamil or diltiazem, it does not affect the sympathetic overdrive at all. It works on the conduction. So what you are going to do, you slow the conduction, but you don't touch the sympathetic overdrive. And if the patient give him an IF channel inhibitor like evaporatin, you are not sorting the problem of the sympathetic overdrive. What you are going to do is that you work on the pacemaker activity and you slow it, and that's not the required one. So slowing heart rate can be achieved, but we need the slowing heart rate achieved via reduction of the sympathetic overflow and not just the heart rate in beats per minute. Now, the third part is beta blocker in the treatment hypertension associated with overdrive. This is important diagram that we have to know as we are treating hypertension. There is no two types of hypertension, I call them. A hypertension for the young and a hypertension for the old. The hypertension for the young is usually associated with diastolic blood pressure. And it is people that young age, and usually in male. And usually it is associated with obesity that increased gradually or increased in a fast way. So the main problem here is raised peripheral resistance, and this patient benefit a lot from the sympathetic overdrive reduction through beta blockers. Patient يجي لك العيادة, he is young, he is obese, and he has high blood pressure, and he has tachycardia, and diastolic blood pressure is high. The first thing to think about it, to give him a beta blockers, because this patient you can eliminate and you can treat him. But going to the old patient, usually female, and when they increase BMI, it goes up slowly, and they have isolated systolic hypertension, then this kind of hypertension is not related to sympathetic overdrive. It is related mostly to increase arterial stiffness, and this patient benefit from calcium channel blocker. So that's why a beta blockers is not a favorable treatment for the elderly, and it should be only given to the patient that they are in need to be given to, because their mechanisms of hypertension is mainly due to sympathetic overdrive. Beta blockers, this is not good. Beta blocker, next. Beta blockers Can you go back, please? And I don't want to make people unhappy of this. Can you go back to? عندكم شي حاجة تانية؟ Is it better? Backward, this is backward. Alish, I'm sorry, I'm not. Yeah, beta blocker can be used in every single step of hypertension because its effect will continue. It reduces the effect of risk factors, prevent progression of the disease from myocardial ischemia to infarction to arrhythmia and death. And in the diabetic patients, all the UKPDS that's known for all diabetologists, that when they compare over the years the ACE inhibitor to beta blocker atenolol, after 12 to 15 years, the two curves diverge in favor of using the beta blockers in these patients because that reduced deaths by 23%. So this shows you the effect of the effect of lowering the heart rate and using beta blockers in a diabetic patient. طبعا احنا كنا at the time say beta blocker in diabetic patients not preferred. They are preventing the tachycardia that usually happen during hypoglycemia. It masks hypoglycemia. But talking on a patient that has sympathetic overdrive with the tachycardia and diabetic, they benefit a lot from beta blockers, and that shows in the UKPDS after years that the curves is in favor of using beta blockers in the patients. When you look at the beta-1 selectivity, it is very important to know that the medicines are classified according to the beta-1 selectivity, and bisoprolol is among them. But we need to avoid the intrinsic sympathomimetic activity that increases the heart rate by beta blockers. And one of them is nebivolol. So nebivolol, as the same as it has a beta-1 activity, it has a partial intrinsic sympathomimetic activity as well. Atenolol doesn't have. So why you need a beta-1 blockers? Because I want to preserve beta-2. The beta-2 is causing bronchodilation and vasodilatation. So what I want to block the tachycardia. I want to reduce the contractility. I don't want to increase the renin release. And that's why in a diabetic patient, when there is an insulin resistance, increased norepinephrine, then we have all these complications, which can be prevented simply by beta blocker. You reduce ventricular arrhythmia and prevent death. And you are reducing the coronary damage or atheroma formation by beta blockers. And you can prevent dipping of the blood pressure or the non-dipping at the blood pressure at night time or nocturnal hypertension. You can reduce the plasma renin activity, reduce the angiotensin II. So the place of beta blocker in the diabetic patient, particularly the obese one, is very important because it prevents all these complications. So you need beta blockers because if the patient has an ischemic heart disease with increased heart rate, you need to slow down the diastole. So the diastolic time, to slow down the heart rate, so diastolic time is long, so patient can perfuse nicely. And in patients that can perfuse nicely, then definitely this will be reflected on his survival, reduction of all-cause mortality, and non-fatal. And he will tell you that each 10 beats per minute reduction in heart rate, it's equivalent to 30% reduction in cardiac death post-MI. This is important slides because it shows you the trials of beta blocker. It's very important to me to see that there is reduction in death in patients with history of coronary heart disease. And that's usually after acute myocardial infarction. Look here, the benefit here, the treatment is much better than the placebo and more better than any other non-beta blocker treatment. So the advice here that any patient that has an MI and you have to continue beta blocker post myocardial infarction to the patient, some authorities say for 1 year, some other for 2 or 3 years, and some prefer to be indefinitely. So beta blockers reduce death, but when it is used after acute myocardial, and even the long-term one, but after acute myocardial infarction, it's very obvious and the effect is very clear. So which beta blocker to use? I would use bisoprolol. Tell me why. Because absorption is more than 90%. The bioavailability is 90% or more. The plasma elimination half-life is long, so it can be used as a single daily dose. It's a balance, 50% renal, 50% hepatic. You don't need dose adjustment in the patient with liver or kidney disease, and you can limit the dose to 10 milligram, even in severe liver or kidney impairment. There is no fear when you have a kidney or liver impairment. Which one to be used? I would use the one that has a high selectivity, and on top of them is bisoprolol, followed by betoxolol, atenolol, metoprolol. So the selectivity I use for the highly selective one. And talking efficacy, it lowers the blood pressure than the comparative, than the amlodipine here, than lisinopril. So the reduction of the blood pressure is very clear in comparison to the others. And then the Nigerian study was compared with other antihypertensive. It shows the same, systolic and diastolic. So potency-wise, it's a potent medication in comparison of the other things. And at the same time, when you talk about the beta-1, beta-2 selectivity, this is have the highest selectivity than any other in the class. Plus, there was a problem that when patients smoke, they tend to have a high blood pressure when you use beta blockers. That's why we always say don't use a beta blocker in a smoker. This is applied on all. Look at the metoprolol. The blood pressure goes higher in a smoker. But when you use the bisoprolol here, the effect is like no beta blockers. So it is safe in a patient that smokes and has hypertension. And the control rate in the smoker is higher here in bisoprolol compared to atenolol after weeks of treatment. Talking about heart rate and covering during 24 hours, the effect of bisoprolol in heart rate slowing is more than metoprolol here. And you can see when you compare atenolol to bisoprolol, you see the bisoprolol control the blood pressure even in the first few hours of the next day. It's always common to hear which is better, nebiprolol or bisoprolol. There's always a question in the meeting. I would say the blood pressure reduction is similar, systolic and diastolic. There's no difference. But the data in beta blockers, in bisoprolol, in heart failure, is by far better in all-cause death, cardiovascular death, in reduction of sudden death. So the data is very clear and high in volume in bisoprolol, but it's moderate in carvedilol, metoprolol, succinate, and nebiprolol. And it is much low in metoprolol tartrate. So if you talk about heart failure and reduction of risk, you talk about metoprolol succinate, but metoprolol tartrate has a very low evidence when you are reducing all-cause death and sudden death in a patient. This is important things we call the link between heart failure and chronic kidney disease. The link is existing in patients with have a higher RAS activation, in patients with sympathetic nervous system activation, in patients with natriuretic peptidase activation. The three of them cause both. And if you look at this one, you see that chronic kidney disease and heart failure, they are causing each disease in each of them. So in heart failure is present in 15% of patients with CKD. And CKD is present in about 41 to 50% of patients because they have many things in common. They have the three important things. They have angiotensin, they have natriuretic peptide, and sympathetic overdrive. And that's why the three favorable medications to be used are ARNI, SGL2, and bisoprolol. What bisoprolol is doing in this combination, this reduces the HFrEF, it controls the blood pressure, and it can be used even in stage 5 chronic kidney disease patient on dialysis, but under medical supervision. 50% dose reduction advised if it is less than GFR less than 30. So the position is there in patient that they have a CKD and heart failure in association. What about safety here? The beta-1 is minimal effect on airway resistance. If you look at the airway resistance, it's much higher with atenolol, but it is markedly low with bisoprolol. That's why it can be used in asthmatic patients. It has no effect on lipid and glucose. And when you're talking about sexual dysfunction, which is a common question, beta blockers and sexual dysfunction, this is the latest article that has published recently, and it shows that bisoprolol is less likely to cause sexual dysfunction. The management of erectile dysfunction patient taking beta blocker is complicated by the possibility of overlapping causes. Hypertension has sexual dysfunction. Ischemic heart disease has sexual dysfunction. So it's not necessarily the beta blocker that's causing the disease. The second thing is dose dependent. Don't give the patient 10 milligram of bisoprolol, because if you reduce this, then the sexual desire will improve. And the other things, it is more in the non-selective one. And the fourth thing that bisoprolol and nebiprolol is less likely to cause erectile dysfunction than any other beta blocker. Therefore, it's preferred for patients experiencing erectile dysfunction. So it is from the overlapping cause, and it is related to the dose, and it is more in the non-selective, and bisoprolol and nebiprolol are the best among the other beta blocker in this regards. So effect on sexual dysfunction would be bisoprolol less effect on sexual dysfunction than other medication in compared one. Let us look in few minutes. I don't want to take much of your time, but we go to three guidelines in regards to beta blockers. The European Society of Hypertension Guidelines, 2023. There is factor that identified that increase sympathetic overactivity. That's why they pay attention to control them. The ambient temperature, the noise, the air pollution as an environmental factor. And lifestyle factor like diet, alcohol, smoking, physical activity, sleep, and the stress. All this increase the sympathetic overactivity. That's why the guideline goes to weight reduction, 1A. Daily physical activity and structured exercise, 1B. Smoking cessation, 1B. Reduce the stress, 2C, because you want to reduce the factors that cause sympathetic overdrive. Beta blocker is among the 5 major drug classes, ACE, ARS, beta blocker, CCB. And the beta blocker should be used if there is associated heart failure, anti-ischemic, and for heart rate control in AF. And you should consider it in presence of other factors like chronic coronary syndrome, post-myocardial infarction, acute coronary syndrome, HFpEF, HFrEF, atrial fibrillation, women at a childbearing period, hypertension disorders in pregnancy. And when you look at beta blocker was here, it can be used as monotherapy at any step of combination. But they are advising starting ACE or R plus CCB, and it controls like 60% of the patient, and add diuretics to control up to 90%. And if this patient is not controlled, then it could be true resistant hypertension So you consult hypertension specialists, and you can add other medication to control the medication. Coming to Saudi Heart Association guideline, I was privileged to be among the group who made the Saudi Heart Association guideline. And it's the same, 40% they are unaware of their blood pressure, and the overall rate control is 50%. The rate of hypertension increased from 25 in 2011 to 29. And the bad thing is that male Saudi university students, 61% suffer from hypertension, and approximately 35% were obese. So that's a very high figure that deserve attention. And we said the same, diuretics, ACE, ARBs, but we add here beta blocker when indicated. So it is among the 5 group, but when it is indicated. And it's good for young age. We say young age, it's associated with sympathetic. Sympathetic overdrive, ischemic disease, heart failure, obesity. Now go to 2024. 2024, I admire it a lot because it categorized the patient into 3 groups. Non-elevated blood pressure less than 120 or less, you don't need to do anything to this patient. Elevated, which goes from 120 to 139, and this patient, you check whether they need treatment or not, based on what I'm going to say, or elevated blood pressure above 140, and then you have to treat them. And that is the level, the corresponding blood pressure during day and night in the 2 groups, which is here in the elevated blood pressure between 120/70 to less than 140/9 as an office blood pressure. The first thing, when you have an elevated blood pressure, when you have elevated blood pressure and you are in the middle group between 120 and 139, you categorize the patient according to the risk. So you look if there is associated established cardiovascular disease or CKD or organ damage or diabetes or familial hypercholesterolemia. If you have them, then you deserve treating them. But if you don't have them, you do score 2 in order to establish the risk and to start treatment. And the elderly, you do score 2 in the older population. Also, to select those group of patients that deserve treatment. And the guideline here does not put a beta blockers among this group, but it was also here that you can use it at any stage of management. But the final thing is start with low dose, double combination, then low dose, triple combination if it doesn't work, and then maximally tolerated dose of triple combination, and if not, you go for adding spironolactone or refer the patient to a specialist. So in summary, the adverse cardiovascular outcome associated with sympathetic overdrive resulted from the urine release of norepinephrine and epinephrine, stimulation of beta-1 receptors in heart and kidney. Sympathetic overdrive is associated with multiple cardiovascular risk factors and is the main cause of hypertension in the young and the middle age. Beta-1 sympathetic overdrive helped to prevent the adverse effect of sympathetic overdrive and could protect the heart at every single stage of cardiac continuum. Beta blockers are recommended in the treatment guidelines in initiation and maintenance of the treatment. Bisoprolol by name is a beta-1 selectivity. It provides effective 24 hours control. It is particularly useful in young hypertensive patients with additional risk, like obese, cigarette smoking, diabetes, high level of stress. These are the patients that benefit a lot from bisoprolol when you have this association. And it is preferred antihypertensive treatment if you have an acute coronary syndrome, if you have a heart failure, if you have ischemia, arrhythmia, tachycardia, fast heart rate, and atrial fibrillation. So thank you very much. شكرا جزيلا.
Thank you so much, Dr. Tahir, for the wonderful presentation. I would like to invite 2 speakers to be in the stage here for the Q&A. And being available here all of you physically, I'll give you the privilege to start the questions from the audience here, if anyone has any question. Anyone? We have many questions. Dr. Abu Nawas. Mic here, please. Another عندك question. Okay.
Thank you very much for this invasive, inclusive talk about pre-diabetic. There is 90%, as you stated, unaware of the pre-diabetic phase. My question regarding, do you go for monotherapy or combined therapy to hit that phase, which is very critical for the beta cells shading down? So how you tackle that problem?
Thank you. Usually, we treat prediabetes with lifestyle and metformin only. This is the only drug allowed according to the Saudi FDA. But off-label, you can use GLP-1, incretin-based GIP, GLP-1, or SGLT2 inhibitor. All are very effective in other trials, not designed to prevent diabetes in patients with prediabetes. But still, the use is off-label. The companies didn't apply to get approval. What we have approved is metformin. And I think lifestyle and metformin will be more than enough. If the patient could maintain some lifestyle and changes and metformin, it will be more than enough to reduce the possibility to progress to diabetes. Thank you.
Okay, thank you.
If I have a question, the microvascular and the macrovascular complications, they start early.
Yes.
And they start in the pre-diabetes. Which one is more common? Is it common in the pre-diabetic to have a microvascular or macrovascular, or there is no comparison?
Because we cannot, thank you, because we cannot evaluate the macrovascular complication that the event, MI or ischemic stroke or something like this, but we can diagnose retinopathy and neuropathy. These are well documented and during pre-diabetes. But the continuum of cardiovascular, macrovascular complication will be there during the pre-diabetic stage. Yeah. But we don't perform a catheterization to look, or angiography to look for the stenosis or the plaque.
You can have a heart failure, for instance, in a patient who is pre-diabetic.
Yes.
At the first presentation, because you are not, if it is caused by diabetes or the diabetic cardiomyopathy, can it be in the pre-diabetic stage as well?
It could be, yes. I mentioned in the macrovascular and the microvascular complications are well documented in the pre-diabetes stage.
So we need to look carefully at this group of patients because the complication can start very early with a microvascular or macrovascular. You don't develop when patients become diabetic. They can develop even earlier, and that is the need for intervention.
That's why we have a cardiologist with us.
Yeah.
These macrovascular complications are there. That's why I put the indication for screening of pre-diabetes. We are not screening for diabetes. Yes. The table, the items I put, the 6 items I put from ADA, it is to screen for pre-diabetes. So we need to screen for pre-diabetes because you will find people who can save them from progressing to the complications.
Yes, thank you so much. It's very nice dialogue, and I truly believe that there is a compelling evidence that pre-diabetes is associated with microvascular and macrovascular complications. And there is one of the study by Don Ziegler. He demonstrated that there is an early necrosis of the C fibers of the microvascular complications of diabetic peripheral neuropathy. It happens in early stage with the pre-diabetic patient. Again, nephropathy, retinopathy, and peripheral neuropathy is always there. And there is always 2 components in pre-diabetes. One is impaired fasting glucose, and the other one is impaired glucose tolerance. And it has been found that impaired glucose tolerance is more predictive for complications of prediabetes, especially when it comes to macrovascular complications. So definitely we have to treat prediabetes as a full-blown picture of of a disease, and we have to be very aggressive to manage this case in early stage. So thank you so much for this. Any other questions? I have a question, Dr. Abdul Hamid, when we call prediabetes as مرحلة ما قبل الإصابة بداء السكري, it makes the people more relaxed that they are still in the early stage, they're not yet there in diabetes. So how about using intermediate hyperglycemia, or as you said, mild to moderate hyperglycemia or diabetes? Do we have to change our terminologies in describing the prediabetes to our patients and public in order to put them on the edge to realize that they are encountering a serious disease?
Thank you. I totally agree. I said patient engagement is very, very important. The patient should be aware about his numbers. What is his fasting? What is his A1C? Not what is vitamin D level. Please try to change the culture. It is not vitamin D that will kill the patient. It is his diabetes or hypertension or dyslipidemia or MI or this. So this is very important. We need to select the terminology that would get the patient engaged with us to start shared management to prevent the progression to diabetes.
Okay, thank you. Dr. Tahir, there is a question says that what is the value of the heart rate variability as a surrogate marker for sympathetic overdrive?
The presence of the heart rate variability, it means that the heart rate is variable during the 24 hours. It goes ups and down. And that is due to the release of norepinephrine and epinephrine in amount that varies during the day. So when, for instance, in the morning, a patient is awakened with a bad dream or a stressful situation, then their blood pressure will go higher up than supposed to be. But at night time it goes low. So this kind of variability during the 24 hours is responsible for major problems. One of them is a rupture of a coronary plaque. And that's why we look for a medication that can pamper this increase in adrenaline and noradrenaline, so we prevent the complication that and that. And that's applied also on other medications that make 24-hour control, because medications that can help in blood pressure variability are either by shutting off the cause or by keeping blood pressure 24 hours. And that's why we always talk about long-acting beta blockers that cover the first few hours of the next day.
Okay.
So that's the link. Yes. And it's very important when you talk about heart rate is to talk about the variability, because the variability is very important as the increased heart rate per se.
Just one moment, please. Excuse me. Variability is not only in the heart rate. Blood pressure variability now is measured, and we need to know the time and target range of the blood pressure. A1C variability is there. Fasting plasma glucose variability, all variabilities are very serious. It is not to have the end result. We need during the 24 hours, the variability should be at the minimum. Yeah. Very important.
And the variability of the heart rate is a very bad one when it is associated with the variability of the blood pressure. So heart rate and blood pressure, when it goes higher and variable during the whole day, did create a very bad effect and a complicated outcome.
Yeah. Dr. Al-Hamid, the conversion of the prediabetes to diabetes, you have mentioned it here in your presentation. If there is any other co-associated factor that enhance the faster progression to diabetes, for example, smoking, obesity, lifestyles on top of prediabetes?
Yes, thank you. All risk factors for prediabetes are there. They will enhance the development of diabetes. As I said, 11% will develop diabetes every year, and 70% by the end of their life, they develop diabetes. Especially if there is both impaired fasting and impaired glucose tolerance together. Both are high. And if the A1C is more than 6%, all these factors will get you be more aggressive to prevent this patient. He has a high possibility to develop diabetes in the near future.
Yeah, and the problem of the prediabetes, once we identify those patients to be in this state, they are reluctant to start medications and they keep on going for lifestyle modification without any use. What is your experience to convince a patient to start metformin in early stage?
Usually, I tell my patient with any of the cardiovascular kidney metabolic syndrome components, we will try whatever you would like to try. But after we evaluate your intervention, if we failed, we should go for another intervention. So if we try lifestyle, let us try lifestyle. 3 months will not have any problem. But if we fail to reduce A1C after 3 months, it means we failed with lifestyle. We will try another intervention that's drug for such. And this is for hypertension, dyslipidemia, obesity, whatever component of the syndrome. If we failed with any intervention, we intensify the intervention.
Okay, thank you so much. Dr. Tahir, the European Society for Hypertension, they have updated their recommendations regarding the use of beta blockers, as you mentioned here. What was the rationale to put beta blockers whenever it's fit based on the patient profile?
You mean the beta blockers was not among the medications
Yes.
that they used to start? Because they talk about blood pressure control as effective reduction of the blood pressure. And it is known from most of the data that the combination of ACE inhibitors and calcium channel blocker, they are better than just beta blockers plus diuretics. And it was shown in ASCO trial and showed in others. So when we talk about the control of the blood pressure, you start with a combination on ACE or ARBs plus the CCB and diuretics as supported by many. But in a special situation where these drugs cannot help the patient or they have a limited benefit, this can be added as an add-on, particularly when the patient is tachycardic or has sympathetic overdrive, or if the patient has an associated disease, and that's common. When you have coronary heart disease, when you have a heart failure, when you have anything, so they have a compelling indication. So they put it aside, that can be used at any stage of managing hypertension if need arises. And I think that is very fair.
Okay, well said. Thank you so much. I think we are coming to the end of our presentations and our scientific event. And before that, I would like to ask our speakers just one statement, if you would like to deliver it to the primary care physicians who are here and online with us regarding management of patients with prediabetes, management and screening those people with sympathetic overdrive hypertension. So what is your recommendation from the clinical, practical point of view?
I want to tell my friends who are facing patients with hypertension in their clinic that patient at a young age, if they come to you obese, young age, tense, anxious, smoking, his heart rate is fast, think of something called sympathetic overdrive. And this kind of patient, they benefit a lot from giving a beta blocker. Don't spend a lot of time to try to see whether this is a secondary hypertension and go for the causes of secondary hypertension. It's obviously clear that this patient could be a sympathetic and beta blocker could be of help to this patient. On the other hand, if he has an old one and exceeding the 60 or 70 or 80, be very careful when you give a beta blocker because the number of beta receptors are less, and the dose that can be good for the young will be dangerous in the old. It slows down the heart rate, it upsets the sinus node, and it can cause problems. And the mechanisms of hypertension in this kind of patient is due to vascular stiffness rather than the sympathetic overdrive.
Yes.
So use it nicely when it is indicated. And the other thing, if you allow me, that if patients recover from an MI or from stenting or from CABG, beta blockers, particularly bisoprolol, are very essential because it improves survival. and introduce complication. So don't stop them after initiating because they are life-saving. Third things, sexual dysfunction, which is physicians are more alert about it more than even the patient themselves. They stop for the sake of sexual dysfunction, which is not linked only to beta blocker. It's linked to the original disease. 40 or 50% of hypertensive patients has sexual dysfunction. And after cabbage, people may have a low desire or low libido. So beta blocker is not the fundamental things. But use the beta-1 selective, use a small dose as much as you can, and then you see a better results. I think that is...
Thank you so much, Dr. Tahir. Dr. Abdul Hamid.
Thank you. Please, patient engagement. Patient should leave your clinic knowing how many problems he has. He has prediabetes, he has obesity, he has dyslipidemia. All this, not vitamin D deficiency, please. We should change the culture of our society. Thank you.
Okay, so on behalf of all of you, ladies and gentlemen, I would like to thank our two eminent, wonderful speakers who have enriched all of us, with this kind of thoughts, and their experience has been delivered to us. So always remember that we have two clinical entities, what is sympathetic overdrive and hypertension in the profile that has been said elegantly by Professor Tahir. So we can use the bisoprolol and prediabetes as a clinical entity that we have to be very aggressive in management, not only with the lifestyle, but also with metformin. With this, I would like to thank you, all of you, for being with us here today. And I would like to thank our attendees online for being with us. And I would like to thank Merck for the wonderful opportunity for giving us these wonderful moments and hours, to share this kind of experience. Thank you for Fexus for organizing this. And thank you for all of you. Looking forward to see you in the episode of the 43rd of the IMC Family Medicine Conference. Shortly, on monthly basis, you will be tuned together, inshallah, to come back again and to share with us this wonderful gathering. Thank you so much. Assalamu alaikum wa rahmatullahi wa barakatuh.